Training webinar is hosted by Max, and those who are not familiar is the Maryland Addiction Consultation Service. And my name is Tracy. I'm going to be helping to facilitate today's training. Max provides support to prescribers and their practices and healthcare teams in addressing the needs of their patients with any substance use disorder or questions about pain management. We offer a free phone consultation or for clinical questions related to substance use disorders. We also help with providing assistance with finding resources for you and your team. We also offer technical assistance to
I think
practice
you're probably just scheduling them.
starting or expanding their office-based treatment, as well as our tele-echo clinics and our Max for Moms program, which supports providers who are treating patients who are pregnant or in the postpartum period with questions again about addiction treatment or pain. We'll put our information into the chat. If you have any questions about Max and our program, you can contact us at any time. I'm now going to go into some housekeeping items. You can use the chat throughout today's training, and we'll definitely have time at the end for questions. A copy of today's slides, as well as the recording, will be uploaded to our website within 1 week. The credit process, which I'm sure folks have questions about. Today's training will be offering CME and CEU credit for social work. In order to receive CME or CEU credit, you must be online for the full duration of today's webinar, and you must complete the evaluation survey within 7 days from today. So that evaluation survey will close next Monday, August 10th. Immediately following today's training, you will be able to access your evaluation by logging into your OASIS portal. And you can complete that survey, and then you'll be able to download your CME or your CEU certificate immediately from OASIS. I'm now happy to introduce our presenter for today. So today we have with us Dr. Max Spaderna. Dr. Spaderna is a physician scientist who has many years of experience treating patients with and conducting research on substance use disorders. He is an associate professor of psychiatry in the Division of Addiction Research and Treatment at the University of Maryland School of Medicine. He is board certified in adult psychiatry by the American Board of Psychiatry and Neurology, and in addiction medicine from the American Board of Preventative Medicine. Since joining the university faculty in 2017, he has worked in several community and addiction psychiatry clinics and in the psych emergency department. Currently, he is the psychiatrist for the health and recovery practice on the Harp Clinic. He provides opioid use disorder treatment by telemedicine to patients at the detention center in Queen Anne's County, Maryland. He provides consultation and psychiatric treatment for the research initiative in infectious diseases use clinic. He has been a principal investigator and co-investigator on several grants. His research interests include suicide risk in the opioid use disorder population, engagement and retention in psychiatric treatment for patients with co-occurring use disorders, intentional opioid overdose, the integration of services for unhoused patients receiving medications for opioid use disorder, and novel uses of medications to treat substance use disorders. So thank you so much, Dr. Spaderna, for being here today. I am now happy to pass it on to you.
Thank you, Tracy, for that lovely introduction. And thank you all for coming here today and listening to my presentation. So just to go back, this will be on trauma and suicide risk and opioid use disorder. And these are the objectives. First, understanding how post-traumatic stress disorder increases suicide risk and how it is overrepresented in opioid use disorder. Two, understanding how suicide risk is elevated in individuals with opioid use disorder. And three, understanding how a history of childhood trauma and suicide attempts differentiate individuals with a history of intentional opioid overdose from those with a history of either unintentional or no opioid overdose. So let's start with the case. This is actually a patient of mine. She's 42 years old. She initially saw me for panic attacks that she was experiencing for about 4 times out of the week. She reported symptoms consistent with generalized anxiety that she rated as a 9 out of 10, 10 being the worst anxiety. Additionally, she described her mood as all over the place. She was struggling with a lot of ruminations, anxiety, especially at night, which caused her difficulties with sleeping at night. She denied any current thoughts to harm herself or any hallucinations. She was also receiving Suboxone 12 milligrams twice a day for opioid use disorder. Her history is significant for recurrent childhood sexual abuse by a neighbor growing up. She was also sexually assaulted by a Lyft driver at the age of 34. She also witnessed the shooting and murder of a 16-year-old boy. She endorsed symptoms of nightmares, hypervigilance, and avoidance from the traumatic events that she had experienced in her life. Her history was notable for 2 suicide attempts, including an overdose on Seroquel and trying to jump out the window. So I think it's helpful to first go over what we mean by post-traumatic stress disorder. Now, these are the DSM-5 criteria. So you first have to have exposure to a traumatic event. This is something where you felt like your life was in danger or that you felt like you could die. Then it's marked by the other symptom clusters. So having intrusive thoughts about it, so including nightmares, flashbacks, avoiding things that remind you of the trauma. That could be certain purses, places, or things that cause people to think about it. Sort of a negative emotional state that can be either just a negative view of the world or it can actually be amnesia for parts of the trauma, and just a change in interest or detachment, and then hyperarousal. So being reminded of the trauma causes people to experience what we think of as a fight or flight response. It has to be going on for longer than 1 month. If it's less than 1 month, we call it acute stress disorder and cause significant impairment. So that's what PTSD is. Now, what is suicide risk? Suicide risk, when we talk about this, are suicidal thoughts, suicidal behavior, and that's it. And this is what confers the risk. Now, you might be asking, why is it that these are the two things that make up suicide risk? And the answer, quite frankly, is this is the best we have. This is the gold standard because we don't have a blood test. We don't have another way of assessing suicide risk. It's really by asking if people are having thoughts to harm themselves and if they're engaging in suicidal behavior. This is admittedly an imperfect measure, but this is still how we assess for it. So this is what we're talking about when we're talking about suicide risk and post-traumatic stress disorder. Now, in the opioid use disorder population, there's a high prevalence of psychiatric illness. This is from a meta-analysis and systematic review, and this shows the pooled prevalences of different psychiatric illnesses and opioid use disorder. And what you can see here is that in the OUD population, they're 18 times more likely to have a depressive diagnosis, over 7 times more likely for anxiety, 7 times more likely for panic disorder, 8 times more likely for bipolar disorder, 9 times more likely for borderline personality disorder, and 9 times more likely for post-traumatic stress disorder. So you can see, one, that the OUD population deals with a significant psychiatric burden, but also with the psychiatric burden, we know that this increases suicide risk. Now, regarding post-traumatic stress disorder, this is from a meta-analysis, and what it does, it pulls the studies looking at studies looking at post-traumatic stress disorder and risk of suicidal behavior. And what you can see here is there's more than double risk of suicidal behavior with post-traumatic stress disorder. So as you can see, just with this diagnosis, that there is an increased risk of suicide and suicide risk. But for the OUD population, which has a high risk, about nine times, more likely to have PTSD than the regular population, their OUD is associated with a greater suicide risk. And there's a few reasons why this might be the case. Now, when we think about what opioid use does, they'll start using opioids, they get an intoxication, a pleasurable feeling. What this does is it leads people to use more. But what happens is over time, this euphoria is followed by a dysphoria, which leads to a withdrawal and negative affect that worsens with chronic use. And what happens is that eventually people switch. So instead of using because they want to achieve that euphoria, they're starting to use the opioids to prevent themselves from having this negative withdrawal state. And this leads to a preoccupation and anticipation to use, which leads to the use and then kind of creates a circle. So this is the circle of addiction. And when you think about the dysphoria that is associated with opioid use disorder, it looks very much like the negative affective state that you see in depression, which increases suicide risk. But there's also a social burden to consider as well. So this shows you the different levels about how we can think about how opioid use disorder affects people on the individual, interpersonal, community, and society level. And each of these has impact on how opioid use disorder affects people in terms of their social burden. Now, we think about in terms of a larger social, society-wide consequence of opioid use disorder, with things that in the mid 2010s from deaths from despair. And basically, what they found, the economist Ann Case and Angus Deaton, that between 1919 and 2015, during macroeconomic slumps, every percentage point increase in unemployment saw a 3.6% rise in opioid death rates and emergency visits. And the fall in the employment rate resulted in both lower life satisfaction and higher drug use among the population. This was an explanation that was used for why there was a reduced life expectancy for working class white Americans, especially in deindustrialized areas and the Rust Belt areas of the United States. But this can be extended to different populations as well. So opioid use disorder is associated with social stigma. This can prevent people from getting life-saving OUD treatment in places, especially states where there was an expansion of Medicaid. They can't afford to actually access the medications, which prevents people from getting the medications for opioid use disorder and makes their OUD worse. They're also more likely to be incarcerated. This not only increases their social burden, but when people are released, we know that that period, that first month or period after they're released from incarceration, their risk for overdose is greatly increased. Now, when we think about suicide risk, when we think about overdose, when we think about how this all affects people with OUD, it's important to think about the impact fentanyl has had. This chart here, as you can see, it shows the number of pills containing fentanyl that law enforcement sees in the US from a short period of time, 2017 to 2023. What you can see, it's an exponential graph. At this point, there is no heroin, at least not in Baltimore, and I think this is the case elsewhere in the United States. It's all been supplanted by fentanyl. Now, what do we know about fentanyl? Fentanyl is many times more potent than heroin. As a result, it is much more dangerous. It's much more likely to cause people to overdose, and as well, result die from opioid use. Now, how does this affect us in terms of with suicide risk? And the question to ask is, we have this much more potent opioid supply now that fentanyl is here. Does this have any effect on suicide risk? And one way to think about this is how does access to lethal means affect people's suicide risk. So this is a study, it's an interesting study, an Australian one. And what they used was they used retrospective data of suicide decedents, so people died of suicide, and looked at their occupations. What they were interested in was did someone's occupation influence how they tried to take their lives by suicide and just their suicide risk in general. So what they found was yes, people who had access to certain lethal means through their occupations were more likely to complete suicide by those means. So if someone had an occupation where they had easy access to firearms or carbon monoxide or poisons, they were more likely to die by suicide by those means. So that was the first thing. But the second thing, as you can see here, is that having an increased access to any lethal means increased the risk of suicide, period. There was a gender divide. So for men, those with access to lethal means were 1.35 times more likely to die by suicide, but for females, it went up to 2.5 times more likely. So what does it show us? That access to lethal means is a risk factor for suicide. When we think about individuals with OUD, what do they have easy access to? Fentanyl, which is lethal. So perhaps this could be an explanation when we see these overdoses that are being marked as unintentional or ambiguous, that perhaps these are stealth suicide attempts and people are using overdoses as a way to die because they have easy access to that. But in order to kind of answer these questions, it's helpful to think more about what suicide risk looks like in the opioid use disorder population. Because even though there are risk factors in this population, and there's a story about why suicide risk would be elevated, there had not been really any studies prospectively following people with individuals with OUD in the community to try to measure what their suicide risk was. So this was a study that a paper written last year in the American Journal on Addictions that looked at the rate of suicide risk in individuals with opioid use disorder. And my collaborators and I were interested in answering three questions. One, what is the rate of suicide risk in opioid use disorder individuals over a 1 year period? Two, does the detection of suicide risk differ by the screening tool used, by the questions asked? And three, what are the characteristics that are associated with suicide risk in opioid use disorder? So that's what we're interested in. And to answer these questions, we use data from the long-term outcomes of opioid using persons, or LOOP. Now, this is a 2 year perspective natural history cohort of individuals with OUD in the community who were followed every 6 months. The N was about 200, and they were recruited from three sites. One, an urban syringe and buprenorphine treatment program located in Washington, D.C. Two, the addiction treatment program associated with the University of Maryland here at Pigtown. And three, a rural mobile buprenorphine treatment program run out of a van in Caroline County, so a rural county in Maryland. To be included in LOOP, individuals had to be at least 18 years old, have met criteria for OUD within the past 3 years. So those were the individuals that we had. And this is how suicide risk was detected in these individuals through these three ways. The ninth item of the Patient Health Questionnaire 9, or the PHQ-9, the suicide domain of the cross-cutting measure, and then the Ask Suicide Questions screening tool, or the Ask. So the Patient Health Questionnaire 9, you can see here the PHQ-9. These are the 9 symptoms that make up major depressive disorder in the DSM. And you can see that they're rated from 0, not at all, to 3, which is nearly every day that people are experiencing these symptoms. Now, the ninth item deals with suicide risk, and this is how the ninth item asks. Over the past 2 weeks, how often have you been bothered by thoughts that you would be better off dead, or thoughts of hurting yourself in some way? So the way that this question asks about suicide risk is asking about both passive suicidal ideation as well as intentionality. Now, the item 9 of the PHQ-9 has been used in studies to detect suicide risk, though it was not designed specifically for this. And it has been used to detect suicide risk in the substance use population. How effectively is it, though, in this population? Well, in one study, 46% of respondents with substance use disorders that reported not at all to this ninth item actually attempted suicide within 90 days. So, based off this evidence, it appears that this question is missing many people who are actually at risk for suicide risk. Now, this is the cross-cutting measure. This is one of the American Psychiatric Association's emerging measures used for further research and clinical evaluation. It was developed to be administered at the initial patient interview and to monitor treatment progress. It's broken down into different psychiatric domains and the different questions to assess it. You can see here that it's rated either 0, none at all, to 4, which is the most severe, which means that the symptom is experienced by the individual nearly every day. So we used the 12th item. Here is actually the 6th, but the version we had was the 12th item that dealt with suicide risk. So the 12th item asked about suicide risk this way. During the past 2 weeks, how much have you been bothered by thoughts of actually hurting yourself? Now, what you can see here is that this only asks about intent to harm self. It does not ask about passive suicidality, unlike the ninth item. So it's actually a stricter language that's using. There's little use of this to assess suicide risk, and less so in substance use population. So it's never had been used in the OUD population. Now, this is the Ask Suicide Screening Questions screening tool, the Ask. It was designed specifically to assess suicide risk. There are 4 items, as you can see. A yes to the first 4 items triggers a 5th asking, are you having thoughts of killing yourself right now? A yes suggests acute suicide risk. That would suggest emergent evaluation. Now, this has been validated in several different populations, including in a substance use clinic, but it never been studied in the OUD population. Now, how does this look like in the general population? So, in population of medically hospitalized adults who are administered the ASK, 15.6% screen positive. So that's pretty high, but it gives you an idea, a comparison of people who were medically hospitalized, going through quite a lot, being medically hospitalized in the hospital, that this was how high the rate of suicide risk was using the ask. So that gives some comparison. So this was the demographics included in our study. So we include about 121 people who had answered the ask. You can see that the median age was 57, so it's a sort of later middle-aged population, predominantly male, about 2/3 male. 4/5 Black, about 2/3 completed at least a high school education. 45% were unstably housed, 15% had no income. This is pretty significant. About 16% reported being physically abused by someone at that point. But you can see here that 38% of this population reported a history of sexual and or physical abuse before age 17. So a population that experienced a lot of childhood abuse. This is what they look like in terms of their substance use. So you can see here that their mean OUD score at day 0 is 4.4, then it went down over time. So that put them into the mild to moderate OUD range. About 17 to 18% were using opioids daily. Most, 9 out of 10, were on medications for opioid use disorder. You can see about 2/3, 60 to 2/3, had urine drug screens positive for opioids. About 45 to 53%, I guess, had drug screens positive for cocaine. About 31% met criteria for hazardous alcohol use at day 0, but this declined over time. You can see there at day 0, and this was only when it was assessed, that 8.3% had reported history of intentional opioid overdose. So pretty high. Now, this is how the screening tools for suicide risk look. So you can see the blue one on the far right is the ASK, the yellow is the PHQ-9 or item 9, and then the green one on the left is the cross-cutting item 12 measure. So you notice a few things. So first off, the ask identifies the most with suicide risk, the greatest amount. So you can see that at day zero, 30% meet criteria for suicide risk. And if you recall, in the data that I presented about adult medically hospitalized patient population, about 15%. So this is double. And this is, a population of individuals with OUD in the community. So they're not necessarily in treatment, they're not in the hospital. But you can see that one, the ask identifies the most, and followed by the PHQ-9, and the cross-cutting measure identifies the least. And at day zero, there are actually 7.5 times more respondents to the ask screening positive for suicide risk than the cross-cutting. And that's has to do with how the cross-cutting measure asks about suicide and how the ask is developed and looks at suicide risk. But you can see that over time, suicide risk is going down. Now, these are the responses to ask. Now, the fourth item asks about a history of suicide attempts by asking, have you ever tried to kill yourself? And that's the one in blue. What you can see here is that about 25% at day zero answered yes. But what's interesting is that over time, that decreases. So not everyone is being consistent in their responses, which is interesting. I also want to highlight that nobody answered yes to the fifth item about having thoughts about killing yourself right now, which is reassuring because this, as a screening tool, could be implemented in an outpatient situation without like overwhelming providers having to make sure they get emergency evaluations for their patients screened positive. So these were the variables that were associated with suicide risk. And I want to go through this just to describe how we figured this out. So the first third are the variables that were only collected at day zero, so only collected once. The bottom two-thirds shows variables that were collected at each time point. So the 3 time points here. And what the model did was it looked at how the variable that we were interested in affected suicide risk at different time points. So the current time point, let's take poor sleep, for instance. The current time point odds ratio, what that says is that if you met criteria for poor sleep at like day zero, or month 6, or month 12, it looked at what was the likelihood that you would meet criteria for suicide risk at, day zero, month 6, or month 12. The 1 time point lag means that if, let's say, you meet criteria for poor sleep at day zero, what's the likelihood of meeting criteria for suicide risk at month 6? Or if you meet criteria for poor sleep at month 6, what's the likelihood that you will meet criteria for suicide risk at month 12? And the 2 time point lag asks, if you meet poor sleep criteria at day zero, what's the likelihood that you will meet criteria for suicide risk at month 12? So that's what that means. But what you can see here is that there are certain variables that are associated with suicide risk. And these are things like intentional opioid overdose history, female gender, or sleep, psychosis, mania, total PHQ-9 score, so depression, psychosis. But notice that really substance use, except for one time point for frequency of opioid use, is associated with suicide risk. So it suggests that it's psychiatric symptoms instead of substance use that is determining suicide risk in this population. Now, I want to talk about intentional opioid overdose because it was significantly associated with suicide risk. And this would make sense because the fourth item of ask asks about the history of suicide attempts. Intentional opioid overdose is a suicide attempt, so naturally they would meet criteria for that. But if you look at the breakdown, what you see is something different. So this looks at the 10 people who had a history of intentional opioid overdose. And it looks at the responses to the fourth item, which asked about a history of suicide attempts. So what you see at day zero is that 9 out of the 10 with a history of intentional opioid overdose answered a history of suicide attempts by the fourth ask item. But there's one person who didn't. So people are not consistently saying that they have a history of suicide attempts, even though they have a history of intentional opioid overdose. But here's what's interesting. If you look at month 6 and month 12, that nine answering yes to ask item number 4 goes down to 7. So not only are people with a history of intentional opioid overdose not consistently saying that these are suicide attempts, but they're not consistently doing this over time. So what can we say about suicide risk in the OUD population based off our data? So one, it was elevated, unchanged over 1 year. It didn't really change. But its detection varies by screening tool. As you can see, the ask identified the most, the cross-cutting measure identified the fewest with suicide risk. This is really an issue of psychiatric illness, not substance use, and is associated with intentional opioid overdose. But as we showed here, it's not totally because intentional opioid overdoses are suicide risks. There's something else going on here. So this led me and my collaborators to ask about like what's going on with intentional opioid overdose. And this is actually something that's under review, looking at intentional opioid overdose in individuals with opioid use disorder. And this is what we are interested in. One, what is the proportion of intentional opioid overdose in OUD? So just trying to see if we can estimate that. And two, we wanted to compare those with and without a history of intentional opioid overdose on different outcomes, whether it be demographic, substance use, psychiatric, and overdose over a 2 year period to see if there are differences between those with a history of intentional opioid overdose versus those with only a history of unintentional opioid overdose or no opioid overdose history at all. So again, we used a loop cohort. We recruited about 193 people into the study. We divided them by whether they had a history of intentional opioid overdose, history of unintentional overdose, or no opioid overdose at the start or during loop. So if they had an intentional opioid overdose or no overdose or an intentional overdose during the study, they were included in this group. And they were assessed every 6 months for 2 years. Now, how did we determine if someone had a history of intentional opioid overdose? Two ways. At day zero, so when they entered the study, people were asked, have you ever intentionally overdosed on heroin or opioids as a way to kill yourself? Someone answered yes, and they were included in the intentional opioid overdose category. But the second way is that we looked at people's responses to ask. So people were administered the ask every 6 months. And if someone answered yes to the fourth item, there was a follow-up question about how did they try to take their life. And if people reported attempting suicide either by overdosing in opioids, whether that be heroin or fentanyl, then they were included in this group. We were actually very conservative about that. So if someone said they'd overdosed, but they didn't explain what they overdosed on, we didn't include them. So we only wanted to include those who had a history of intentional opioid overdose. So this is how we came up with these groups. So this shows the breakdown. So at day zero, here represented by MO, you can see that there were 73 people who reported no opioid overdose history, 106 who reported a history of only unintentional opioid overdose, and then 14 who reported a history of intentional opioid overdose. Now, what you can see is between month 0 and month 6, there were 4 people from the no overdose category that had an unintentional opioid overdose. So they were switched to the unintentional group. And then between month 12 and month 18, there was another person from the no overdose group that had an unintentional overdose, and they were moved over to that group. And then between month 18 and 24, there were 3 people from the no overdose group that moved into the unintentional group. Likewise, between month 18 and month 24, there was someone from the unintentional group that had an intentional opioid overdose, so they were moved to the intentional group. So the 65, 113, and 15, these were the groups that we used to look at variables. So this is what we found. These are odds ratios by overdose group, IO being the intentional group, NO being the no overdose group, UOB the unintentional opioid overdose group. And what you can see here, the variables that were more associated with intentional opioid overdose than in the no overdose or the unintentional overdose groups were a history of physical or sexual trauma before the age of 17, a self-reported history of suicide attempt. Those were the two ones. Importantly, substance use outcomes did not differentiate intentional opioid overdose from like the no overdose group or the unintentional group. So what was differentiating it was this history of childhood trauma and a history of suicide attempts. Now, this looks at continuous scores. The PHQ-9 was measuring depression. The GAD-7 was measuring generalized anxiety, and the OUD score was measuring OUD severity. So what you can see here is that in the intentional group, they had higher scores of depression by PHQ-9 and anxiety by GAD-7. But OUD severity was similar between the IO and the UO groups. So basically, what's marking intentional opioid overdose is different from the other two groups is not the severity of their opioid use disorder, but the severity of the depression and their anxiety. Now, this gives you an idea of the probability. If you see someone who reports a history of intentional opioid overdose, what's the likelihood that they would say that they have a history of physical and or sexual trauma before age 17? As you can see here, the probability is 0.93. So 93% probability that someone with a history of intentional opioid overdose would have experienced a history of physical and or sexual trauma as a child. That's astronomically high. You also see that about 90% would report a history of suicide attempts. So very, very high probabilities of not just histories of suicide attempts, but also of significant abuse. But look at the unintentional group for a moment and the no overdose group. You can see here that the unintentional group is 49%. It's 53% of no overdose. So this is a population that's experiencing a lot of childhood trauma. And you can see even in the unintentional and the no overdose groups that there's high rates of suicide attempts. So this just shows you how much trauma there is in this population. Now, we didn't look at PTSD. We didn't rate PTSD in this population. But what you can see here is that this is a patient population with a lot of trauma that has an elevated suicide risk. And it suggests that there is high rates of PTSD in this population that is likely driving the suicide risk and the importance of doing more research into this. Now, I want to talk about the treatment because it's something that you might be interested in how I approach this because in this patient population, and again, I treat patients here at the addiction treatment program with opioid use disorder, really their psychiatric illness, less so for their OUD treatment, but I see trauma here, PTSD, almost everyone has it. So I've gotten comfortable with treating it. And these are the things that I like. So the alpha-1 adrenergic blockers like prazosin and doxazocin. Now, if you look into medical literature, there's questions about whether they work, but they're in my practice and in my experience, these are effective for PTSD symptoms. And the randomized control trial that people talk about, like the VA had significant problems. So even though it was a null study, I don't think that it was a very representative study for PTSD. So this often is my first line. And the reason is that for the patients that I see, they need immediate relief. So this helps to calm those hyper aroused symptoms, the re-experiencing the flashbacks, the nightmares. SSRIs and SNRIs have a lot of evidence base, and I will use those. Those take some time, though, to work. So it can take a few weeks, but it's important to encourage people. But these are effective for PTSD. Other antidepressants like mirtazapine can be helpful. There's a role for lamotrigine, evidence about its use. The thing with lamotrigine to be aware of, it takes about 6 weeks to titrate up to its effective dose because you want to reduce the risk of Stevens-Johnson syndrome, incredibly rare, but it's life-threatening. So it can take time with that. I will manage with other medication symptoms that can be antipsychotics. I have used benzodiazepines. I try to avoid, but in a situation where if someone's really bad anxiety and they're monitored and I feel comfortable, there are therapies that help, like prolonged exposure. But these are the treatments that help to treat PTSD. So I want to conclude just what to take away from all this information. So PTSD, it's associated with OUD and suicide risk. And there's an elevated exposure of trauma in opioid use disorder populations to keep in mind. The childhood trauma is associated with intentional opioid overdose. And what this means is that there's a significant need for psychiatric care. So if you're treating this population for the psychiatric illness or just in general, one, inquire about their needs for psychiatric treatment. And if you're a psychiatrist treating this population, think about the trauma that they likely experienced and if this could account for a lot of the symptoms. Again, the patient that we saw before having horrible panic attacks, but a lot of this was due to this horrible trauma history, both in childhood and adult, that was causing PTSD. So that's what I have. And now I want to just leave up to everyone here if they have any questions or anything that you want to discuss or that wanted to go over.
Thank you so much, Dr. Spoderna. That was wonderful. And yes, as you said, if you have questions, please feel free to put them in the chat. You're welcome to unmute if you would like, if that's easier to ask the question, but we do have time for some Q&A, so please feel free. You can also unraise your hand if you would like, if that's helpful. So I did see someone who put a question in the chat.
Yeah,
They asked, have there been any studies on suicide attempts that assess how many actual changes in risk or protective factors have happened before the attempt?
that's a good question. I can't think of any study that would look at that. Are you looking at seeing how something like psychiatric treatment would mitigate suicide risk or in individuals with opioid use disorder? Is that basically the question?
They said they put again in the chat, right, to be extra aware of red flags.
Yeah. So I'm not aware of any studies. My understanding is that there's not a lot of research into this topic specifically with psychiatric illness and OUD, and less so about suicide risk and intentional opioid overdose. What I would say, just as a clinician, that psychiatric treatment is really crucial for mitigating risk, even if people still experience a lot of post-traumatic stress symptoms. Having people involved in psychiatric treatment makes a big difference. At the addiction treatment program here at the University of Maryland, we co-locate their OUD treatment and substance use treatment, psychiatric care, and the primary care. That's wonderful because it's one-stop shopping for our patients. It prevents fragmented care. And for many people who have difficulty trying to engage with a psychiatrist, either because of access or it's hard to get to different places, it's an easy way for us to make it easier. And it makes a big difference. There is, however, a real need to study this more, to look at ways that we can screen for this. One thing that I was actually at applied for an R21, and even though I'm going to be leaving University of Maryland soon, I'm hoping will continue to be explored is how do we screen for intentional opioid overdose? It's not easy, it's not straightforward. You can't just screen for it, well, according to data, like we would for suicide risk. So there's a real need to understand this more, to do better qualitative research. I've done some, which I'm hoping to get published maybe before I leave, but more research is needed to answer these questions.
Thank you very much. Again, if you do have a question, please feel free. You can unmute, you can raise your hand, you can put it into the chat, but we do still have some time for questions. I'm happy kind of in the interim, as folks, if you think of questions, to go over some more housekeeping items, some reminders. Again, a copy of these slides and the reporting will be available on our website within 1 week from today. They will also be emailed to you as well. Continuing education credit. Again, this webinar offered CME and CEU credit for social work. You need to complete the evaluation that is must be completed within 1 week from today. So that evaluation will close at the end of the day next Monday, August 10th. And you need to complete that eval survey, and then you can download your CME and CEU certificate immediately after completing that evaluation survey. If you have any questions about the process or anything, you can email us at the Max Training email, and our team is happy to help. But again, we do still have a few minutes. If you have any questions, please feel free to unmute, put it into the chat. Well, thank you so much, Dr. Spadurna. That was, as always, a wonderful presentation.
My
Thank you
pleasure.
for taking the time out of your schedule, and for everyone who joined for taking time out of your busy afternoon. We can go ahead and end. We can put a few more kind of things into the chat. We do have some upcoming trainings that we have this summer, or into the fall, as we are planning the fall. So we can put our education page into the chat. I am happy to stay on for a few extra minutes if anyone has any questions related to the program, accessing CME, CEU, kind of those things. But we can finish. So I hope everyone has a wonderful afternoon, a great August. Enjoy the rest of summer. And thank you again, Dr. Spadurna. That was wonderful.
All right. Thank you so much.
Thank
Appreciate it.
you.
Take care, everyone.